Hi, everybody. My name is Aleysa, and I'm from another Norwegian company. And now we'll be talking about solely radium-224 standardization today and how we use it, not how it's done. That's somebody else. But yeah. So right now we have our main product named Radspherin. We got clinical phase 1 completed. That means that the product has proved to be safe. And also the word our medical department is used. It has shown promising efficiency. That means that 60 patients that were treated were a good result and a real success. But they are very careful with their words because it can happen that we just were so lucky with the patients. And when we expand the cohort, we end up seeing, okay, but just to put it in perspective, we are radioactivity people here. We know a little bit about probabilities, and we can imagine like if result is really good in 60 cases, what happens when we expand it? There is always chance there are different results. There is high likeliness of another good result. And what happens with us closer to the subject? We have, with tiny company, we have a single site of production in Oslo. We produce a batch of 1 to 4 patient doses, and we ship them to different hospitals in 4 countries so far. And we're expanding, and next phase of clinical trial starting April will be more sites, more countries, more patients. Yeah, and I just cannot help maybe bragging a little bit about the company. It was founded by 2 people who also founded or started with what is known as Xofigo now. And I'm a chemist myself. I really like chelators and peptides and molecules and things. But what these guys did with Xofigo, for example, is where everyone was going for fancy or fancier phosphonates, collagen mimetics, whatnot. They were radium chloride, bomb. And chemists, I have a mixed feelings about it myself. Like, was it that simple? But it's so efficient that that's really impressive. And yeah, this is my boss. Some of you know her, and she is responsible for making this, the things the guy invent, make them work for the clinics, for the patients, and deliver it into from the idea to the bed. And what Radspherin is another not unlike Xofigo concept, because what our patients are is colorectal and ovarian cancer patients, which are known to develop metastasis in specific sites, more specifically in the peritoneal cavity. So the idea here is, all right, it's hard to think of a fancy molecule that will go directly to colorectal sites for now, maybe. But what we can do is we can use the natural body feature, which is peritoneal cavity, and keep the radioactivity inside of it to deliver it where it's needed by having just a colloid. It's so simple. It's calcium carbonate colloid adsorbed on which radium is adsorbed. And radium 224 in our case has nice daughters here that will deliver all the energy in the peritoneal cavity. Now, our job as QC people is to be very sure that the specific dose that was planned to deliver to a patient is delivered. And to prove it, as a part of it, to prove it to authorities, we say we're giving patients 7 megas, and this is how we prove it. So chain is like this. In here, we work hand in hand with production, and then we ship to the clinics. And here are the instruments that we use. In production, they can do with a dose calibrator here and there, and in clinics, they have nothing but dose calibrator. And in QC, we look more into details and we use HPGs. Yeah, and in fact, in clinics, they use dose calibrators only to check what is it that they're injected. What they base the information on is our documentation certificates of analysis. So those calibrators can be different models and different vendors, but what they are is basically ionization chambers, very reliable, very simple. All you need is to be very sure about your dial setting. And that is done under our close supervision by sending them, and I don't know if you can see it here, but there is a table, an instruction, and something even a technician can follow. We send it to the clinics, and from how they feel the papers we send, sometimes we can see, okay, this was filled by a physicist because there is certain tiny little difference in few signs after a comma. So they send it back to us. We carefully look at it and say them, thumbs up. We could have sent, there is an instruction for what we do when we don't see the correct result, but that never happened so far. So that's one thing. But the other thing, in that certificate that we send along with the sample, calibration standard, or in fact a patient vial, it happens in the same way. How do we know that the activity in the vial is as it's supposed to be? And for this specific product, we measure it with HPG, and that is because when the product is fresh, all the daughters may not be there. And in fact, since there is a little bit of chemistry involved, so daughters can be washed out, and we don't really know. We cannot say, okay, separation time is this, curves is like so, dial setting is that. We cannot afford that. This is why we have to do HPG analysis. So we measure radium-224 peak. We make some calculations. We make a certificate and state the activity in this vial has so-and-so concentration. And for the traceability thing, I have heard an argument, all right, HPGs are super reliable. What you need is correct library and a calibrated instrument. And here is tiny vial, that's European standard, with a NIST stamp on it, saying, this is your traceability. And it, especially when the person puts it that way and makes a lot of smart sentences, it may seem that that's enough, but that's not, because there is a lot of things to that. It's not as simple as one peak. There is sample geometry that Aleysa mentioned. There are parts of sample preparation details that can affect the result of each measurement. Sample size, there can be something different with the distance from the detector. There can be something with the counting time. We can mess with our result by just counting longer and using certain decay corrections settings, for example, if we wanted to. Interference, of course. So here on the left, there is a spectrum of radium freshly separated from daughters. Lead peak is super tiny, but in time, that peak will grow, and does that affect the radium result? That is for us in QC to determine. And this is why we have our guidelines. And this is funny that way. These guidelines are written by pharmacists and for pharmacists. Each and every radiochemist I have seen looking at this text first time, yeah, it is hard. I have to say it is hard because, but after a while, you begin to adjust it to radiopharmacy, which is tricky, but it is adjustable to radiopharmacy. So what you need then is to develop a test that will prove to authorities and everyone involved, yes, what we measure is what we measure. And that is when we need standardization. Because, for example, this is a nice illustration. Say linearity test for the validation. Validation of the method, right, is how we prove that the method is working. And we have to prove it to everyone who will be interested in looking into it. It has to be perfect. And in the end of this perfect chain of arguments, there should be something concrete. And that is our traceability to, say, NIST or a different standardization institute who is known by everybody in the world and trusted by everybody. So here on the X, we see true values. And that, funny as it is, for a very precise HPG measurement, we use as a true value dose calibrator measurements, because those are traceable to NIST. Yep. And that is backed up by the work of standardization people. And if you ask what metrologists can and actually do for us, is this. We need our standards. We need concrete data available for authorities to show this specific ionization chamber is reliable, very reliable. And this is why all our other instruments that we validate using this specific chamber is reliable. And in the end, this is how we can tell you what we inject into the patients is exactly what we wanted to inject. Nothing else, no mistake can be done anywhere in this way. So this is actual chain of how it happened. Standardization happens. We communicate it between the company or manufacturer and standardization institute, and this in our case is NIST and NPL. Then we help clinics with the data, and then patient gets what they have to get. Yeah, and this is group of people who've been doing standardization. I'm only using it, but this is not full, but most of the people who have done standardization for us so far and continue doing so. Yeah, and this is all I had to say. Are there any questions?